welcome everyone to our Optimising Recall Systems Efficiency in Action. My name's Sarah Chappell. I'm with Redmore Health. We've also got two colleagues from Redmore Health on the call. We've got Kylie and Stacey. And then in addition to that, we've got Dr. Simon Doyle, who is from Abtrace, and we have got Sachin Gupta and Harris Reid from Hippo Labs. So we're going to run through a few bits initially before we pass over to Abtrace and Hippo Labs. Everybody's microphone and camera is able to be turned on if you wish. We do want it to be an informative conversation, really. We want interactions from you guys. So by all means, just turn your mic on if you want to come in with a question or anything like that. We will have questions and answers at the end, though. Initially, could you all put your name, job title, and where you're from, where you're working in the chat? That would be great. If you could all be doing that now, that would be brilliant. So, if we're looking at this slide, it's just to let you know that obviously, as you all will know, the NHS is facing growing pressure to improve patient care, and there's limited resources. Patients expect personalised care, easy access to information, and seamless digital interactions. There's new technologies out there, as we're all becoming aware of, such as your AI and telemedicines and things like that. These things are transforming healthcare. Kylie? Yeah.
You're not, these slides aren't sharing.
They're not sharing? I wonder why, just bear with me.
Well, can everyone else see them?
I can see a slide in front of me, yeah.
Right, okay. It's me, sorry.
Oh, okay. It's gone off at my side now. Where's it gone?
Yeah, we're back on that first one with the trends.
Here we go. It's coming up. It's just really slow. Sorry about that. So yeah, as I was saying, all these technologies are transforming healthcare. They're improving diagnoses and treatment and patient engagement, which is really, really important. Collaboration and clear communication is obviously key to adapting these technologies. Also, what needs to be considered is challenges in primary care, such as rising demand, more patients with long-term conditions, obviously. Those registers grow each year. We've got workforce strains, staff shortages and admin overload. And then obviously it's balancing priorities, so managing QoF while ensuring the patient care, which is really important. I've also got to think about data quality. Is it accurate? Have you got accurate registers? And then improving proactive care rather than reactive care. Also considering digital tools, other structured workflows in place, and automation that can reduce workload. Obviously, that is increasing more and more. And then we've got to consider making recalls work. So obviously, as I've said, primary care teams juggle QoF. They're looking at multimorbidities, data accuracy, and then you've got to think about effective recall and improving outcomes and reducing stress levels as well. We'll explore streamlined workflows a little bit, batch messaging and digital tools to make patient care more efficient. I want to now ask you guys to join in a little bit. So you can either turn your mics on, you can pop it in the chat, whichever you feel more comfortable doing. So if you just let us know what your current process is regarding recalls, such as do you use birthday mums, risk stratification, etc. So who wants to come in on that? Anybody? Anybody that uses birthday mums currently for your recall process? So you're all a little shy today. I will just tell you, I've come from a practice manager background, and before leaving, our process was birthday months, but we need to consider, is that becoming a little outdated? And right, okay, someone's popped in the chat that some use Ardens with birthday months, some use System 1 recalls. Okay, so yeah, birthday months, is that becoming a little outdated really, when there's all these technologies out there that can improve things? And also thinking about your multimorbidities, are you capturing everybody within your birthday months for everything like that? But yeah, if anybody does want to speak up, please don't be shy. We want this to be as interactive as possible. So I am going to pass over to Kylie for the next slide. Can you take control, Kylie? Yeah.
Thank you. So accurate disease registers are key to effective long-term condition management. Regular audits help find missing codes or overdue reviews, improving both QoF and patient care. Online services such as records access, electronic prescriptions, electronic repeat dispensing, and online appointments can streamline processes, reducing admin steps. Risk stratification helps prioritise high-need patients, moving beyond a basic QoF checklist. Batch messaging automates recalls, ensuring patients are contacted at the right time via their preferred methods, the text message, the NHS app, or via the phone. So some key actions: to audit and clean the registers by fixing coding errors, remove any duplicates and complete missing data. Use risk stratification to focus on patients with higher needs, not just QoF targets. Automate recalls, so schedule reminders based on clinical need. Improve accessibility, so offer online booking and flexible response options. This keeps processes clear, concise, and actionable. Digital tools help reduce admin workload and improve patient engagement. Automation such as AI chatbots, batch messaging, and reminders cuts DNAs and increases uptake. Integrating messages into workflows ensures responses are automatically recorded in the patient's records, reducing the manual input. Regular monitoring of response rates and patient feedback can help refine strategies for maximum efficiency. And then choosing the right communication method. So text messages, these can be used for quick reminders such as flu vaccines. Phone calls can be used for complex or sensitive issues. Social media and websites should be used for more general updates, so your opening hours, public health campaigns, things like that. By standardising recall templates for SNOMED coded messages, practices can ensure accuracy and consistency while saving time. Automating reminders using AI-driven tools and batch messages helps improve follow-ups and reduce missed appointments. Selecting the right communication method ensures patients receive clear, relevant information while reducing unnecessary practice work. Understanding a patient's readiness for digital access helps encourage those who are willing and able, while also supporting those who could engage but currently don't. In a Camden PCM project, we analysed patient data to identify those already digitally activated. For example, those ordering prescriptions online. This helped us assess how many more patients could be educated to shift towards digital services. Encouraging patients to change how they access services requires an understanding of their current level of activation. By moving more patients from groups 2 and 3 into groups 1, we free up resources to better support those in group 4 who need more help. This approach ensures a targeted, efficient strategy for increasing a digital adoption while improving access for all. I'm now going to hand over to Hippo, and they can present theirs.
Awesome. Are we all good to kick off? Yeah?
Yeah, we are. Thanks, Harris.
Cool. I'm just going to share my screen with you, and I'm going to try to keep this as close to 15 minutes as I can. So I don't really want to waffle on too much. I'm just going to share my screen. Can everyone see my screen?
We can. Yep.
Awesome. Okay. Lovely to meet you all. My name is Harris. I'm an implementation manager here at Hippo Labs. And today I'm going to be taking you through a quick overview of our tool, Hippo. And I just want to show you some impact that we've had with practices, PCNs, who are using our recall automation tool. And yeah, I'm just going to take you through some of the basics. So moving through into the first slide, just to give a bit of a background on us, if it's going to work here. So we're founded in 2021 by our CEO called Sachin, and essentially he worked in NHS in primary care for around about 4 years, and he managed a group of, I think, around about 4 or 5 practices, and he was coming up against all the issues that I hear about every single day. That recall management for long-term conditions is a complete burden, not just on his admin staff, but it was also on his clinical staff and management team as well. And he basically thought, there has to be a better way of running this process. So he tried Ardens, tried Accurex, tried Excel, and he just found that it didn't really tick all the boxes. So he made Hippo for his own practices and had some great success. So a little bit just on our background. So I've spoken with over 120 practices in the last few months. Honestly, it's been some pretty crazy times here. And the majority of practices I speak to find long-term condition management completely overwhelming for their teams. And I've really tried to share like the most relevant information on this webinar today, just some like key bullet points. It doesn't cover everything, otherwise I could talk about this all day. But just some feedback and reasons around like the problems that teams are facing currently with their processes. So practices are currently their problems. Sorry, focus on the first one. Is out of date, inefficient systems. So lots of practices are, working off tools with not so much, automation, and it fails to keep pace. So if anyone is ill or maybe, leaves a practice as well, sometimes these systems are just basically left in the dark, and colleagues don't keep on top of them. So recalls, long-term conditions, invites gets pushed to the back of the pile. Another problem is around rising demand. So I feel everyone is working with systems that worked, 10 years ago, but with, the uprise in maybe like list size or the amount of patients with long-term conditions, it's a strain on their resources. And then health inequality, so barriers like language and digital access actually worsens care gaps as well. And I think digital access can be not just for your patients, but also through your practice staff team as well. So a lot of care coordinators or admin staff that I speak to don't like getting involved in it with tools because they don't quite understand them correctly. So the challenges I see is obviously completely manual processes with inviting patients in, and in that risk element as well. So, not keeping on top of your follow-up and creating errors. Limited capacity, so just not enough time spent on recalls. So, other priorities that the team need to keep on top of. Low response rates, so patient engagement. Standard practice processes are using, text or letters. The majority don't use things like NHS apps, so it just creates a very low response rate. And I think the standard response rate uptake is around about 20%. And then staff burden as well. And the impact that actually has on practices is, poor recall rates on staff, increased stress, something that you touched on earlier, and as well as the increased stress, I actually find that, it's such a repetitive task that admin teams, will actually leave the surgery because all they're doing, is coding and sending out messages. It's not a very enjoyable task, and the impact on patients is delayed care, what's not something that we thrive towards. And I think one of the main points that, apart from tools like Arden and Accurex, who don't really massively focus on like automation, recall processes for long-term conditions, QoF, haven't really changed in 20 years. It's still incredibly manual. I feel like I'm speeding through these slides. So what I'm going to do now is just take you through a very brief overview, not a demo, of our recall call automation tool, Hippo, and basically how it works in a surgery, a PCN, a federation. It doesn't just have to be used at sort of single practice level, it could be used at group level as well. So the first point in here is basically we integrate with one or multiple clinical systems, and we have constant data transfer back and forth. So our system is always bringing the data over, running searches essentially, and identifying what patients need what care. And that can just be with, one thing they need to come in for, or again, touching on like the multi-morbid element here. So if a patient needs to come in for, 5 different things at once, it's all about matching them up and inviting them into the right appointment. So once we've identified what patients need what care, what we'll do is we'll invite them in automatically into the surgery. And with our invitations, we see standard around about a 50 to 60% uptake in our outbound messages, and what's huge compared to the standard response rate of about 20%. We communicate over 5 different channels, that include NHS app, WhatsApp, text, email, letters. And what we'll do is we'll schedule first, second, third, fourth message out to your patients, basically like a reminder. We'll communicate in the patient's language of choice. We'll send out messages at optimum times. So we're basically learning how your patients respond, and Hippo is adapting over time to create even a higher uptake. So typically practices who use Hippo really see their benefits over time when Hippo learns how to communicate with your patients. So anyone who books in that's great, book directly in to cover multiple things at once, but anyone who doesn't book in would fall through onto a manual recall list for practice, like care coordinators to basically call through. It's sort of like a mop-up list, as we're covering all of the invitations and sending out the messages and identifying the patients. The only thing that the team needs to keep on top of now is the manual recall list, because everything else is being done. We also have a BI tool built into Hippo for your team to basically assess data and pre-plan like appointments, things like that, but maybe not something we'll deep dive into today. So for practices, PCNs, federations, and what does it mean? So massively reduces workload, that I'm going to get to in a minute. Increases income. You hit your targets earlier in the year. With the uptake, there's a lot higher chance of hitting these targets for your income, and overall just providing better care, because there's no risk element. Hippo's not going to become ill, or go off for 2 weeks on holiday to Spain. It's always going to continue to be there. So what I wanted to do is just show you through a quick case study that I wanted to share today of a practice who has used Hippo across a number of targets. And this is a very, very recent case study. So I thought we'd include this today. So it's Nightingale Surgery, and they've got about 5,000 list size. So the background and challenge they were facing, is pretty much the same challenges that I see every single day speaking to, a huge amount of practices. It always seems to be the same problems that come up. So Nightingale, had high admin costs, and the admin team was spending a huge amount of time on these processes. And even though they were sending out the messages and ticking the boxes to saying, we've invited these patients in, they weren't, getting the results they wanted. So in this case as well, they had low response rates. So they tried traditional methods, sending texts and letters and, trying to call their patients, but there was no structure. Inefficiencies with existing tools. Accurex and Ardens are two to mention. They are absolutely brilliant tools. I just think for the maybe the recall side, it still requires a heavy amount of manual workload for teams. And then the last was missed opportunities for care. So their patients weren't being seen when they needed to.
Harris, could I
Yes.
just ask a quick question? We've got a question in chat. Does it code into the record automatically? And how
Yes.
about booking links?
Booking links, it books directly into your books, and it will only send messages out when there's appointments available. So, you know, if there's appointment, it will basically send messages across all the different cohorts. Once it sends out a message, it will code it directly back into a clinical system, for every single message, and you can use QoF codes or non-QoF codes, completely up to you.
Yeah, so it'll pick up the codes, won't it? So if a clinician hasn't actually coded anything, it'll not pick that up. It just picks the codes up.
Yes, it will pick
Yeah,
the codes
yeah,
up.
yeah.
Yeah.
Brilliant, thank you.
Cool, right, coming back into the solution of Hippo. So these are some key points on why Nightingale basically chose Hippo and the things that we helped them with. So the first was around patient engagement. So how Hippo could send personalized messages across multiple channels, SMS, text, NHS app, WhatsApp, and email. NHS app and WhatsApp, we get some really good response rates on, especially for them difficult targets. I'll get through to that in a minute. You know, but patients book directly in with their team. Next is on tracking and analyzing responses. We spoke about that, but basically Hippo is going to use your data to communicate with your patients more effectively over time, and then integrating seamlessly, just on the point you asked on. So, you know, we plug straight into their clinical system. We have all their data, and we're going to only be sending out the messages to the patients who actually require the different types of care. So the results. So just across 4 targets, we achieved a 50% uptake, 42, 35, and 27. And overall, just from these 4 targets alone, we saved around about 62 days in admin time and saved over £6,400 for this practice. So this is just across these 4 targets alone. And it's just within admin as well. This doesn't include, you know, clinical time and management time. And we've just focused on the actual time spent on recalling these patients. So we have a bit of a deep dive here. I'm just checking my 15 minutes. I've done 12 and a half. So speed through. With diabetes, before Hippo, they were achieving around about 20%. And with Hippo, they achieved a 53% conversion rate. And we booked over 275 patients with them and saved them around about 6 days in admin time. For flu, a very, very, very hard cohort this year. Their conversion rate was 20%, and we've brought that up to 50% with Hippo. As you can see here, we saved them around £4,000 in admin costs, and we booked around about 1,300 appointments with them without any human intervention. And then their child IMS campaign was a very, very hard cohort anyway, took them from 20% to 35% conversion rate. And overall, these are the stats we've taken from all of their different cohorts with us. Achieved a 50% conversion rate, conversion rate. It's not the right word for it. Booked them 2,600 appointment and saved them about £11,500. What's the aim of the game here, isn't it? So the last thing that I wanted to talk about was the cost of inaction. And practices that I speak to don't realise how deep this goes until they actually really dig into it. So when I speak to practices at the beginning of the call, they're like, oh yeah, we only spend, you know, a couple of hours on this, that. But when we really dig into this, you know, there's, in the standard practice, there'll be multiple teams working on this. And, you know, towards the end of the QoF year as well, it seems to be a bit manic. And I think just what, you know, you mentioned earlier, Sarah, I think that just comes down to the birth month recall, but maybe a conversation for another day. But I've broken it down into 3 different points. So a whole receptionist will be managing this process. What I see, clinicians not being booked for multi-morbid appointments as well. So wasting time and having to get involved at the end of the year QoF rush, and then management as well, just throughout the whole year, having to keep on top of this. So it is a big task. Yeah. And with 14 and a half minutes, I'm going to call that there.
Brilliant. Thank you very much, Harris. Kylie, do you want to take over?
Yeah, thank you for that, Harris. my screen. Okay, so we're now going to hear from Simon, who is from Abtrace.
Sorry, just trying to take control of those slides. Do you mind just sharing again and then I'll grab it? Thanks. In the meantime, I'll introduce myself. Hi, everyone. Simon Doyle, one of the GPs that works at Abtrace. So I'm based in London, so still work clinically in North Central London. If anyone is based locally, hello, nice to join you here today. And for those that don't know about Abtrace, I'll be explaining a little bit about what we do. I think we won't need to labour the point in terms of what the problem is, because we've all heard that already, and it's great that you're already here, so probably already understand the problem. And I will get going from here. Okay, how does that work? You're able to see the right screen because I can see the presenter mode.
Yeah, we can see it.
Yeah.
Perfect. Okay, so start off just explain a little bit about who we are if you haven't heard of us already. So we are a health tech company solving this problem, basically. We are based in London, but we have offices here and actually in Portugal as well, where part of some of the founders live. Our founder, similar to Hippo's story, is a doctor as well, and we're quite a clinician-heavy team, to be honest, myself included. And we are live in over 32, I think, of the 42 ICSs now, and we're covering over 3 million patients a day. We are fully certified as a medical device, and we are fully integrated with EMIS and System 1, which means we can access a huge amount of data, and that's partly what we're going to talk about today and how we use that. So normally I would explain and outlay the problem that we are all completely familiar with and we've already heard today. But just to focus slightly on this slide, what we want to do and what everyone is in agreement with is we need to be focusing on prevention rather than just the reactive care. But the environmental factors make that really hard. We know that staffing shortages exist, budget cuts exist. The reality is that forces us to focus on the right-hand side of this slide and focus on the reactive. What that results in is we think around 6 million patients being overdue a monitoring requirement, and that could be anything. We're not just talking about QOF here, it's safe prescribing, it's locally enhanced services, it's NHS health checks, there's a heap of different things that we can be checking. We also anticipate that reactive model means that around 2/3 of appointments are what we class as suboptimal. So what I mean by suboptimal is I've seen a patient in my clinic, but I didn't realize that they were due a blood pressure for something else. I didn't do it. I've let them walk out. Ultimately, they're going to have to be called back again. We think that equates to around 30 million appointments being wasted each year. We can move towards the left side of this diagram. Other industries have done it. We've seen it done in logistics. We've seen it done in finance more recently. And the common denominator is always tech. And it's great that everyone's here today because that shows that you are thinking outside the box and being proactive. And it's great to hear there's lots of different solutions that are achieving similar things because ultimately we can all then push each other to create the best product. Having said that, this is what my day looks like normally. So this is my day as a GP. So clinic starts in the morning, then I do scripts, letters, meetings over lunch, clinic, scripts, urgent results, admin referrals. That's me just trying to get through the day. The bits around the outside are the things that we're probably talking about today, and that's the bits that we see as a distraction instead of our core work. And that's because there's so much floating around there. So it could be learning disability reviews, it could be CQC monitoring, DKCP, NICE, CKS. I mean, as many acronyms as you could possibly imagine, they're probably floating around in the back of our heads somewhere when we're trying to work clinically. The second part of the problem, the way I see it, is when we start talking about long-term conditions and multiple long-term conditions, it's so easy for us to be on the left side here and to picture somebody with multiple long-term conditions like this, frail, sick, in need of our help. But the reality is the person on the right-hand side could have NDH, they could have CKD, they could have hypertension. So they could have 3 LTCs, completely asymptomatic, and feel like they don't need to be going to the doctor all the time. They don't need to be recalled. They don't want to be recalled. So that's part of the problem as well. We need to reframe how we think about our patients. And the solution ultimately lies in trying to get as much done as possible in as few visits as possible. And that's what we're all trying to do, because that's better for patients, better for our practice, it's better for our staff who are forever looking at pop-ups and kicking themselves when they've let someone walk out the door. So I'll just pause before I show you what we've done in terms of a case study and the concept of abtrace. The best way I try and describe this is we know that there are all of those different things floating around in the back of our heads in terms of monitoring needs, CKS, QoF, local things, health checks, SPS. In an ideal world, I would have someone in my practice sitting, going through all of those searches, tearing their hair out, running population reporting, one after another in EMIS or clinical reporting in System 1 to work out where our patients lie, whether they're up to date or whether they're overdue. Better still, I'd want them to build a search to show when they're going to become overdue so we can get them first. That's not going to happen. We don't have the money for that. EMIS and System 1 can't cope with it. So that's why abtrace exists. That's what happens every night. So we're running all of those searches and cross-referencing with all of the patient data. So the medications that they're on, the results that we have for them to see where they're up to. And then it's just basically, very basically presented in the morning as either red if something's overdue, green if it's up to date, and amber if it's still in date but will time out soon. I want to walk you through what we've done with the practice. So the background is there was a really quite poorly performing practice in terms of recall. The recall was quite ad hoc. I think, Sarah, you mentioned it earlier, or somebody did, maybe it was yourself, Harris, around people retiring. And basically the recall system here was a house of cards. This person retired, the system was really unclear, there was no plan of succession, no one was trained up, and it had kind of fallen off the radar. They were aware that it had fallen off the radar, and they were really panicked about it, and they had a huge backlog, particularly in terms of medication monitoring, because they were just focusing on QoF to try and get as much remuneration as they could. What they did, they actually ended up being taken over by a nearby practice, is the reality, both around 10,000 population. The other practice had recently implemented abtrace and were getting on really well with it. So they used the whole circumstance, the takeover, this poor person retiring, as a bit of a burning platform for change, and they really shook things up in the practice. What we did is we were able to share learnings from our existing practice that we were already working with and other practices across England. We worked with them to map the skills mix of the staff, because that's so often a bit of a barrier. So you have someone who can do COPD, but they can't do a foot check, or you have someone who can do the bloods, but they can't do something else. So we mapped that with them, and we designed an annual recall system instead. We then set up automations for the ongoing medication safety backlog that we knew was in the background. So the practice were then confident that they had a plan for how to catch up with the things that they'd missed, but also going forward, things were only going to get better. This is what it looked like in reality. So this is our software. So it sits side by side with EMIS or System 1. So similar to how you would have Document open separately, you'd have abtrace open separately. You can see here on the left, I'm just going through and adding the QoF registers that we want to add into the recall. And you can see how quick on the right-hand side, the patient list is just changing. So much quicker than if this was actually being run as a report. I then filtered on the left side, you can see for patients who were overdue, because we want to worry about those who have already missed, but also more importantly, the opportunistic. So this time of year, for example, it's February, people might come up as what we classify as orange because they were part of the mad scramble last year and they had their blood pressure checked in end of February or beginning of March. So they've technically not timed out of their 12 months, but we know we need to get it done anyway between now and April. So get it done now, don't wait until they turn red. It's a bit small on here, but you can see there's some exclusions. So similar to how Harris was talking about, we've excluded housebound patients here, plenty of other things you can exclude as well, palliative care, care home, residential home, etc. And then there's the simple option of either exporting this as a list, which is great. That's sped up the process of the status quo as I see it. So we've managed to remove the need to run the reports, but we still need to action it. And that therefore means someone hands me a spreadsheet, I still need to upload it into another messaging tool, which is, I think, only doing half the job. So the better thing is you can just batch message through this. So select all and message them. You are due, you're overdue, whatever it is. And importantly, you can associate the right invite code with that message. And there's no hidden costs in terms of having PCM pressure about fragment costs or ICB pressure about how many messages have you sent. It's all just included as the package, which is really helpful, including the booking links. So what I can do from here, or One of the things we could have done, which we didn't, and I'll explain why in a second, was just batch message these people with a booking link, associated QOF invite codes. Great, brilliant. Therefore, we've done one invite. Problem is, I'm going to have to do that again next week, or 2 weeks' time to give them their second invite, or in 3 weeks' time to give them the third, whatever it is. Or, you know, if you've got a 3-week wait for appointments, then there's no point messaging them before then. So what we did instead is we automated this process. So what you can do with Abtrace is save all of the search criteria that we've done in the left side for whatever works for your skill mix, whatever works for your practice and appointment slot types. And basically just tell Abtrace, hey, remember what we've set up and do that every week. So you can go through these different stages, and the slides are probably a little bit small, but basically what you can see here is there's 5 simple steps to set this up as an automation. We talked a bit about birth month. Is birth month out of date? Controversial, who knows? There's many ways to skin a cat, and ultimately the best way to run recall, I think, is to run recall in a way that's going to work to capture as many people in your practice for in as simple way as possible for your staff. So we do include recall by birth month as an option. It's not the only way to do it. The way I see birth month positives are, it's great for patients in that they don't have to come in many times. If you do on demand, it's actually possibly more efficient for practices to just message people when they're due things. But that's kind of the learnings we can share from different practices. Here, though, we did actually do birth month because they didn't have any system. They wanted to know that they're staggering their workload throughout the year. So we set it up to recall by birth month, meaning that Abtrace would just, for example, be messaging the February patients now, turns to March, it starts messaging the March patients, etc., etc. Similarly, you can actually get a month ahead and start doing next month now. So if, for example, this morning I set up a practice as next month birth month recall, so there's messaging March patients now. When it comes to March, they'll start on next year's. You're able to then go through, just simply, I'll show you very quickly, pick the days of the week you want it to run, how many patients you want to stagger by, mapping with your capacity, basically. If you know you've only got one person doing blood tests, there's no point messaging 300 people a week because that's never going to work. So making it sensible in line with whatever the capacity is and the order of priority as well. So oldest first, most overdue first. People with the most things needed is one option. So you can target those people who have 10 overdue things first versus the people who have only one overdue thing to try and capture as many things as possible. Importantly, this is where you can add the slot types, and you can add the slot types by staff member, site, booking slot type. And then you can write your message, decide whether it's text or email, whichever order you want to do. And importantly, in terms of box ticking, the right code. What happens then is that's going to run in the background. So it's going to, you can set and forget almost. You get a report each time it runs saying, Simon was not contacted because I've got a dissent code, or I don't have a right mobile number, or I've actually reached my maximum number of attempts, which you can set so that we're not just messaging the same patients ad nauseum and we're actually getting through the list. The great thing is it really simplifies what happens when patients come in. So at this practice, we really focused on making sure everyone was comfortable with the bit of Abtrace that they need to know. So not overwhelming people. Change is really hard to implement. So you need to make it as simple as possible for people. So we did tailored sessions, for example, with the HCAs, who were just going to focus on this part. They didn't need to know all of the really clever stuff about how the patients have got there necessarily, unless they were interested, which is great. But what they needed to know is when a patient comes in, you use this part of Abtrace, which shows you really clearly a jobs list. So it's green if it's up to date, it's orange if it's going to time out soon, it's red if it's overdue. So if I've seen this patient previously and booked them in for bloods, but I didn't think of doing a renal profile, the person who sees them knows that this is licensed as a medical device. They can click down to expand and see why it's needed if they want to, but ultimately they know that they're empowered to do it. And staff really like that, not having to contact the duty doctor, contact reception, what do I need to do, who needs to request this, because they're empowered to be able to actually action it. None of this matters if our coding isn't right. And I feel like until I started this role properly with Abtrace, I'd never fully understood the importance of coding. And now I understand so clearly why the partners I've worked with previously have been so hot on it. This was never actually meant to be part of our product. It was never meant to be the core product. We realized that we had all of this information. We've got so much data, so why not present it back to our customers in a way that's really easy to use, in a way that helps them to regain lots of their investment. So basically, this is representing the information back to practices, and this practice used the CKD recommendations really well, which I'm going to show you in a second, to say which patients are missing from your registers. So really big bang for your bucks or anything that's numbers based. CKD is so easy to miss the second EGFR being less than 60, busy duty doctor, just file it as normal. Whereas this will just simply show, consider adding this patient to CKD register, gives you a reason why, tells you the date they met the criteria, open an EMIS, click accept, done. Updated, and that's about £4 for your prevalence for CKD per patient. So it's really helpful in doing that. And the more important thing is they're then going to pull through to that population view for any other requirements and start to be recalled appropriately for whichever condition we've added to their problem list. How's it actually worked? So this practice, there's a couple of ways. Hypertension doesn't need an appointment, really quick filtering, took 60 seconds. Within 5 days, 73% of their blood pressures were up to date of the list that they had to work through, which is incredible. Quaff revenue, so they went through all those CKD recommendations. They accepted 98% of them. They just hadn't actually actioned the last couple. They hadn't rejected them when I last checked in on them. And their quaff revenue for the CKD register for their prevalence increased by 75% compared to the previous year. And that's going to stay at 75% increased as well for next year. And like I say, if there's any different requirements that are needed, those patients are going to flag to be monitored appropriately. In terms of impact from opportunistic things, not letting patients leave, we looked at the practice before AbTrace was implemented and afterwards. What we're showing here is we want things to be as green as possible and as little red as possible. Basically, if a patient comes in and they had everything done that they needed, they left. When they left, they show up as green on this chart. If they leave with something still outstanding, then they show up as orange. Or opportunistic, sorry, so it's that thing that wasn't timed out yet but will time out soon, that's the orange. And if they leave with something overdue still, that's really bad, and that's the red. So we can see we went from about 20% of fully effective appointments to over 40% within the first couple of months when we reviewed their data, which is incredible. Similarly, that can be applied across PTN, so you can compare different sites and track how usage is going, and then you can map the effectiveness and how green things are compared to the utilization of the tool as well. And we can then really focus on our training and upskilling within the practice. Last two bits, I promise. Staff level, the response is always brilliant. So people feel really overwhelmed by this, which I think we all do when we're trying to map this. One practice said to me that they felt like they've been spinning on their heads for ages and now they can just let it run. Another practice commented that they're drowning with dashboards. The PCN have given them a dashboard. They know that they're performing badly, but there's no point in that if you can't action it. Whereas this was able to actually convert into actions really quickly. And the pharmacists there on the bottom right there, you can see loved it because it does the complex bits like DOACs as well as the simple things. More importantly, and this is the last thing I want to comment on, is how does this impact the patient? So this is just a timeline of one financial year for a patient who needs a BP check, they've got SMI, diabetes, they're on some thyroxine. So this patient attends for an injury in the first quarter of the year. They happen to have their blood pressure checked and their smoking status brilliant, some opportunistic monitoring there, but then they're recalled later on for the diabetes review, have their foot check in their bloods, then they're recalled, then they run out of their thyroxine, they haven't had their TFTs in that diabetes review, so they only get a short script, so they have to contact again. Then they're called again for their SMI review later in the year. This patient's just not going to turn up by the time we get to the SMI review. So what we can do instead, by thinking about it in the best possible way for both us as running the recall, but also for our patients, is to structure it properly. So the alternative is we recall these patients for an annual review, have their blood pressure checked, smoking status, diabetes review, foot check, everything syncs up as much as possible. They're still going to come in for that injury. They're still going to run out of that thyroxine because they forgot to put their repeat in, but their TFTs are up to date. It can just be reissued. Patient's happy, we're happy, things are a lot smoother. if we do all this, we know that we can reduce about a third of appointments. Practices make their return on investment with that optimization, the case finding in about 3 months, and we save huge amounts of workload from admin staff, around 23 hours a week, we think. I'm going to pause there because I'm over my time by a minute or two, I think. But I will happily take any questions.
Yeah, there is one question in chat. So you mentioned that you can do the multiple recalls, but does it code each individual recall?
Yeah,
when
so
you
different
put them
practices,
together?
if I've understood your question correctly, different practices seem to do it differently. So, and from a QOF point of view, the actual rule is they need a QOF indicator invite. So people tend to get really tied up in what we're doing in terms of they need to have a first invite, they need to have a second invite. They actually just need 2 invite codes, whichever they are. You can use 2/3 invites, you can use 3/3 invites. So that's one part of it. And similarly, we don't technically need to have a diabetes recall invite on there or a hypertension invite and a CKD invite. So we just need the actual overarching QOF invite code. So that's what lots of practices actually do. And that meets the QOF requirements. There is the alternative, you can put the individual ones in instead if you prefer.
Okay.
Through
Okay.
Abtrace, so that when you set that up, it will just code that each time.
Right. Okay. Moving forward. Right. That's fine. Does anybody want to come in and ask any questions at this point on either of the presentations just shown at all? No. What about do people currently use florries? Do they send florries prior to like recall reviews to gather that information to save clinical time, things like that? What's current process? I just want to know. Right, okay. Amy said it would be good to know about costs. So we will cover that. What we can do is we can send on the contact details for that to be able to be shared with you guys. I think that would be better to do it that way, if that's all right. So does anybody want to talk about florries at all? Do they gather the information prior to seeing the patients to save on time and things like that? I just want a little bit of interaction if you're not too shy. I'll leave it with you. You can pop it in chat if you want to. Kylie?
Thank you. So as you take steps to optimize your workflows, improve patient activation and integrate digital tools, having the right support can make all the difference. While technology is a powerful enabler, processes, people and strategy are just as important when embedding sustainable change. Our digital and transformation managed service provides tailored hands-on support, whether through a 12-week project or a longer-term collaboration. We help assess digital readiness, develop data-driven strategies, and implement practical solutions that align with your clinical priorities. For those working at ICB levels, supporting popular health planning and integrated neighbourhood teams is increasingly important. We offer guidance on using real-time data insights to drive proactive care and ensure resources are directed where they needed most. If you'd like to discuss how we could support your next steps, we're more than happy to have a chat and explore what would work best for your organisation.
Okay, so if you haven't already, this is just some information on our D&T network. So the previous slide that Kylie spoke about is a D&T hub, and practices and PCNs can complete different assessments within that D&T hub that gives them sort of an action list to say, right, we need to focus on this area, or this area. However, this is D&T network. So anybody can join this that's working in primary care. It's free to join, and there's a wealth of resources and information on there, as well as some great conversations. You can add topics in there if you want people to join in conversations from your point of view. It's all about things digital and transformation in primary care. So really, really useful things on there. It includes a community forum, free webinars, regular newsletters, exclusive white papers, resources and templates, and free events as well. You can scan the QR code that's currently on the screen now, and that will take you to register. So I would say it's really, really useful for anyone in primary care, definitely. So there you go. You can take a screenshot of that if you want. And then we will just move on to, does anyone want to ask any questions at all? Do you want to open up your mic and come on and ask anything at all about what we've covered today? Somebody's put in chat that ideally they would use Flores. However, it's quite a lot of work already for recalls, which, yeah, I understand that it is. They do use it for heart failure reviews, but things like ACT scores need to be done on the day and things. So yeah, you have to think about the clinical things that need doing as well. Back to any questions. Anybody want to come forward at all? Don't worry if you don't. It's fine. So then, if you would like to leave us some feedback on today's session, there's a QR code on this screen, or we can, oh, hold on, Sarah, can you send us some details on pricing rather than just contact details to find out? Yeah, we will do. We'll send some pricing info over. We can send it to those that have registered. I can't see that being an issue. Any other questions at all? No? We've got a few minutes if anybody does want to ask anything. But as I said, if you'd like to leave us some feedback, this QR code on the screen currently is the way that you can do that. Somebody's just typing in chat, so we'll just wait a minute. Right, okay. Can recalls be customised to local quality contracts? So, for example, if you've got your local enhanced services and things like that, or
Yeah, so we do that quite frequently. We have a team of clinical coders who are mainly pharmacists, just because pharmacists are so good at attention to detail, aren't they? And we frequently do that for areas. So that could be, annoyingly, since the NHS health checks changed to local authority, they're all slightly different. So that could be one of them, or it could be locally enhanced services. We just need the service specification and the details of everything you want, and then yeah, we just get it coded in. So for your user, they just know that everything on there is what they need to be doing. They don't really need to know if it's because of DKCP for diabetes or is it CKS. So it's all just in there.
And the exact same thing over at Hippo as well. So you come on board with us, would be matching it to your current processes, and anything that needs to be chopped and changed throughout the time with us, we would add in as well for you guys.
So you can tailor it to the practice needs or PCN needs
as
needed.
Exactly.
That's great. Thank you. So Dr. Doyle's just put some information in the chat on costings. If you want to do the same, Harris, that's probably best way. And there's also a link in there from Dr. Doyle about booking a demo. Do you want to do the same, Harris, as well? And then that information's out there, if that's all right. Anything else that anyone wants to ask while we've got a few minutes left, if anyone wants to ask anything? Yeah, so there's some costing in there from Harris as well. So yeah, we'll send out any information that's needed after this, but if you've got any questions, please don't hesitate to ask later on. That's fine. Right, thank you everyone. Got a few minutes left, but we'll let you go and grab a cup of tea. Thank you very much for joining us. Thanks, Harris, and thanks, Dr. Doyle. It's been really useful.
Thanks, everyone.
Thank you.
Okie doke. Bye-bye.
Cheers.
Bye.
You've just got a chance.